Hi, this is Jacob Workin. I'm going to talk to you about logging cases. Here's some objectives of what we're going to do. Uh, More or less, you go to this website. If you Google ACGME case log, that's where you're going to show up, and it's going to look something like this when you finally put in your credentials, kind of some basic stuff. The case ID is important. That's a little notifier to let the ACGM know, what this patient is. There'll be some more about that detail. More or less everything with an asterisk, obviously, you just need to fill out. The rotation can be trauma or general surgery. The resident role is important. We'll discuss that shortly. Pretty much you're always at Mount Carmel unless you're on transplant or peds. And then obviously the attending, and for the most part, every patient is an adult unless you're at Nationwide. Uh, and obviously also the resident year and case date. So just fill it out. It's not too tough. On the right, you can see a couple menu items. Edit cases does exactly that. Reports menu is important. That can help you see where you're standing. You can also download all of the cases you've ever done with the download cases menu. If you scroll down a little bit, that'll be where you log in your CPT codes. Some general rules about case logging: don't use two codes for one case. It's a waste. You basically bundle two things into one thing, and it doesn't really mean any difference. Now, if you do two parts to a case, you know, the dilemma always becomes, well, does this case have parts to it that in and of themselves, maybe you could legitimately log as two different things? Some people are against it, some people are for it. I personally, if you legitimately do an umbilical hernia and then a separate incision, inguinal hernia, I don't feel bad with logging two separate cases for one case, if that makes sense. But some things like splenic flexure mobilization with a sigmoid colectomy, putting those two codes for one operation doesn't really change anything. So I don't really log a splenic flexure mobilization if I do a sigmoid colectomy. So that's kind of what I mean with don't log two codes for one case. It's not going to change anything. When in doubt, when you don't know what you're going to do, ask a friend. There's plenty of us that have done this for a long time now. And the important thing to remember too is get familiar with these codes, because these codes are what actually pay your bills eventually. So knowing the ins and outs or the minutia can really help you out. When you do a ventral hernia repair and you do a intermediate complexity wound closure, that's a separate code. In the future, you can get billed for. And you get reimbursed for it. So it's important to kind of look at these and kind of know a little bit about them. And some of these codes, though, are not perfect. That's why I have square peg, round circle. You have to kind of find what's going to work for you. Neck fash, there's an actual debridement of skin and soft tissue, but it doesn't count as a major code. So you need to find a code that works for you. And there's some debridement codes and whatnot, but just look for a code that's going to work for you, that's going to be a loggable case, because otherwise then it's a waste of your time, and we don't want to have that. So how do you log these cases? Again, you find the FIN number or the MRN number. Those are the most common things people use. So in the top right corner of Power Chart, you can write this down. It's on stickers. Um, the end all be all is it doesn't really matter. The main thing is the ACGME just needs to be able to look up a patient, so that way if they need to audit something for some reason, they can find a patient identifier and look things up. When you're logging the case, kind of like I mentioned on that slide, 2 slides earlier, just fill out the rest of it. The main thing, though, be reminded of is you're a surgeon junior in pretty much all scenarios except for your chief year, and then you can log things as the surgeon chief. Another kind of moral dilemma kind of scenario is well, what does it mean to be a surgeon junior? Well, to do 50% of the critical portions of a case. Otherwise, if you're just standing there and the trocar closer, you're kind of a teaching assistant at that point. As you get more advanced in your intern year, Dr. Vera may become blind all of a sudden after he's clipped the duct in the artery in a gallbladder case, and he asks you to come over and, since he can't see, take the gallbladder off the liver bed. And to be quite frank, I feel like that's at 50% of the case. That's an important part of the case. And so there's delineations in different cases similar to that where you legitimately are doing 50% of the case, and so you're a surgeon junior. So just be reminded that you're kind of the person that makes this ultimate decision. And so, log it accordingly. And then finally, as I mentioned, you're going to log the CPT code. What are you going to log? You want to log everything. Me as a chief, when I started out, I didn't really log like chest tubes and difficult IVs and stuff, and those don't really mean anything. But I mean, those are things that you can log. And when you start looking at these again from a reimbursement standpoint in the future, there's some things that seem silly, but physician placing the Foley catheter. I mean, that's a in the RVU world, that's a procedure you can get some RVUs for it, or even in private practice, that's something you can bill for. So the key though is from a number standpoint, if it's not for major credit, it doesn't count. So if it has that tag, it's not going to mean anything for your master case log that you're going to send in when you become a chief to get basically to become a fellow. Every procedure that you log in a hospital can be beneficial to log. And so, again, kind of like in my example, early cases where you're doing, a perirectal or perianal abscess drainage, that's actually a major case. So just because you don't go to the operating room doesn't mean that it's not something that you can't log. So just always be mindful of whatever you do. If it's a procedure, think, can I log it? Because it might come to benefit you in the future. Again, look at the logs, see what codes are there because those are important. They may help you in the future getting paid. And don't forget to log your endoscopy cases. So, PEG tubes, upper endoscopy, C-scopes, flex SIGs. All those also have different codes if you use a snare polypectomy or a forceps biopsy. So just be on the lookout for those. Where do you find these codes? Well, Google is your friend, but the easiest thing is just use the search bar at the bottom on the ACGME app. But in some places, like I said, for Google, just Google what is the CPT code for laparoscopic cholecystectomy. You'll find it pretty easy, and then you can just copy the code and then paste it in the search bar, and you'll be able to have that code pop up. Some endoscopy cases in Provation, which is the program we use here at our hospital. It has the code listed, so you can just copy it. When you're at Taylor Station, they also already have it on the operative schedule, so you can just copy it. If you really struggle, you can always go to the OR desk. They might have it listed as well. But for the most part, you can search for it and find it just through the app itself. And some things are a little bit difficult, and so to tease through them, you just have to pick out the keyword that you want. And again, it's always beneficial to just look at some of these in your spare time. When should you log these? Well, I personally do it every time I finish a case. You're sitting down on the computer, you're doing orders, you're putting them maybe on the patient list. It literally takes 1 minute to log in, put the code in, and put in the rest of the information, and you're done. You don't have to think about it. I don't carry a book with me. I don't, that's something else that I can lose or I can forget to grab a sticker, and it's just another thing to lose and to be frustrated with. Some people do it at the end of the week. Some people do them every 4 months or every year, which is terrible because then you end up spending hours and hours and hours logging cases. So the choice is yours. So, in your 4th and 5th year, you might start caring about where numbers are starting to fall along. Are you having enough anal rectal cases, which is a historic thing that we tend to run low on. You can always, on that menu, as I mentioned, you can download cases and look at all the cases you've ever logged. And you can search, did I put down a not for major credit, case? Some cases, can go either way. So, like a Whipple, it's an endocrine case, but it also could be a pancreas case. So whatever number you need, you can change the category based upon that. You might accidentally put surgeon chief instead of surgeon junior or other things, and so that's what the edit cases menu. You just search, maybe the patient identifier or the category of surgeon juniors, and you can see everything that you've ever done before and change things accordingly. It's pretty easy, self-explanatory. This is probably the least favorite part of this entire thing, and that is the surgeon, more or less the non-operative stuff. So the trauma leader resuscitation, that is a series of things that you have to log, and more or less the kind of idea is if someone has CPR or massive transfusion, you're more or less leading a team in resuscitation. The log number for that is 92950. You need 10 of those. Surgical critical care, these are basically critically ill patients in the ICU that you're managing. They can be trauma patients, but you tend to try to have these as be, just critical care patients, general surgery critical care patients. And there's when you log this code, there's about 7 different things that pop up. You need to have at least 2 categories selected for each patient. So you know whether or not they're managing their ventilator, their bleeding, organ dysfunction. You can read. And you need 40 of those. And the non-operative trauma, you need 40 of those. I apologize for not writing this in, but the code for that is 99199. And you need 40 of these. And so what is this? Well, patients with organ dysfunction that don't require the operating room, but more or less they need babysitting. This is what the ACGME says about it. It says it's a category defined as patients with major organ trauma who were admitted to a specialty care unit in the hospital. The most senior resident kind of claims this code, and if the patient subsequently requires a general surgery operation procedure, that may be claimed in the defined category. So that's that. So hopefully this was beneficial and informative. If you have any questions, obviously ask your senior residents. They'll be able to help you out, and good luck in the future.